Dean Reynolds will not be joining us this morning. The University of Maryland is having its graduation ceremonies, so he needs to be there. So let's start. I have a few announcements. We have a new member from the Maryland Department of Health, Nancy Brown. She is the Division Chief of Evaluation Research and Data Analytics with the Office of Innovation, Research, and Development. Hi, Nancy. I'll let you introduce yourself to the group.
Hi, everyone. My name is Nancy Brown. I'm a Division Chief within Maryland Medicaid in its Office of Innovation, Research, and Development. I was actually here at the first meeting of this group to provide an update on our oral health JCR. So happy to join you as a full-time member.
Thank you, and we're happy to have you. Next, I'd like to talk about the next few months in the schedule and the reporting of the subgroups. Our next meeting is scheduled for June 16th, and we decided to give everyone an opportunity. We would alternate the times between an AM meeting and a PM meeting. And so the next meeting is scheduled for June 16th at 4 p.m. And at that meeting, we'd like two of the subgroups to report. That would be the elderly group and adult group. And for your reporting, what we would like to see is for you to talk about the population needs, what the access issues are, and suggested solution or solutions. For a July meeting, that will be July 21st. That will be a 10 a.m. meeting. And that we would like for the disabled group and the Medicaid group to report. And our August meeting, August 18th, will be a 4 p.m. meeting. And we would like the immigrant and the pediatric to report. And once everyone, that gives us a chance to gather all the information and then give you a report to look at in September for review for the final report, which will be due in December. And I wanted to mention, we submitted the interim report. You all have seen it, and it's not been submitted to the legislation because we're still waiting for MDH approval. So that has to occur before it can be submitted. My last announcement, and we didn't mention this the last time, but there's been $19 million allocated in the governor's budget for a rate increase in Medicaid. So it hasn't been determined how it will occur, but it's expected to begin July 1. And there will not be any addition of any new codes. So we just wanted to let everyone know that that has been allocated. Any questions about anything? Okay. So we're very happy to have two speakers today. So we'll get started. Our first speaker will be Mr. Matthew Peters, and he is the Executive Director of the Chesapeake Multicultural Resource Center. So, Mr. Peters, I will turn it over to you.
Just checking. Everyone can hear me okay?
Yes.
Okay, good. So I'm Matthew Peters. I'm the Executive Director of the Chesapeake Multicultural Resource Center. We are a nonprofit organization established here in Easton, Maryland. Our mission is to engage and empower people from different cultures to become successful members of our community. So we've been running this organization since 2012. To date, we've provided services to over 5,500 clients of the immigrant community, and representing in that 65 different nationalities. So we have a lot of experience under our belt now, coming on 10 years. So I'm just going to go kind of through and show you what it is we do at the center and a little bit about our community that we serve. You can go to the next slide.
At 140 mLs.
So this is over the 10 years, again, based here out of Easton. Most of our clients do come from Talbot County, followed by Caroline County, Queen Anne's County, Dorchester, parts of Delaware, down to Wycomico County and beyond. And then we are getting an increase of clients from what we call the Western Shore, which would be around Annapolis, Baltimore, and the DC area. So what we see in our office every day, again, based on those 5,000 plus clients we've seen, most of the clients we see every day come from Guatemala, followed by Mexico, Honduras, Haiti, Salvador, Venezuela, Pakistan, and then the other 60 or 58 different nationalities just make up that other 1 or 2% of our client base. Move to the next slide. So over the past 9 years, what we've really tried to do, and our most important resource we have here, is our staff. We really look for the best in our community that come from the community and represent the community we serve. So obviously I'm not an immigrant myself. I'm born in America. I did spend 13 years living and working in Guatemala. So with that 57% of clients that come from Guatemala, I have a little more understanding than most would about where they're coming from. I've been to most of all the villages and towns there in Guatemala. Living there 13 years is a pretty good idea of the history and what a lot of our families have gone through or are going through at the moment. Our assistant director, Estella, she comes from Honduras. She came as an undocumented or unaccompanied minor when she was 14, went through the school system, lived most of her life undocumented. She was granted DACA in 2012, 2013. That's kind of when she got associated with working for us. We were able to look at her file very closely with a number of immigration attorneys and able to sponsor her for a green card. So she's now a legal permanent resident. Victoria Gomez from Mexico. She's been here for about 8 years in our community. She serves as our primary outreach coordinator. Jennifer just graduated from high school about 3 years ago. She's born in the United States, but comes from a family from Salvador. Ingrid came in 2014 as an unaccompanied minor, just became a U.S. citizen last year, and that's when we picked her up to be part of our team. Jackie is a current dreamer, a DACA recipient, coming from Mexico. And Omama, our chief finance director, is from Pakistan and helps us kind of work with those clients as well, from Pakistan, Afghanistan, and she does speak a number of languages. So what we've been seeing is kind of over the past 10 years are where are the gaps in the community, those gaps that don't quite understand the immigrant experience, don't understand that there are differences, legal differences in working with immigrants and U.S. citizens. So we've really kind of worked with our clients and with partner organizations to see where those gaps occur. The biggest gap has been in providing immigration work and services. So we went ahead and became an accredited Department of Justice organization, meaning I can legally represent clients with certain immigration cases. And then we do that 100% free of charge. I average right now 12 cases a week I take on, mainly on citizenship cases, family petitions, green cards, work permits, DACA, TPS. And we're able to do all that 100% free of charge. And we do have a great team of kind of supervising attorneys across the state that look over our work and make sure we're doing a good job and accurate work for them. Because even though it's free, we need to make sure there's also quality work as well. So we're able to kind of close that gap as much as we can here without having attorneys on staff to provide that. Two of our staff are health insurance certified navigators, meaning they can directly provide assistance in getting our families signed up for Medicaid or for other types of insurance. Most of our time here in our office by all our staff is sent by sorting through hospital doctor bills, health services. It's very complicated when you go to the hospital and get 3 or 4 bills coming in. So we're very experienced with sitting down with all that, mapping out a plan, applying for forgiveness for a lot of those that can't be forgiven, setting up some sort of payment schedule that fits the client and what they can do, and kind of help them sort that out and put them on track with getting a primary care doctor and anticipating any future illness that they might have. All of us here in our center are bilingual. So we've gone through training programs so we can not only just be bilingual, but have the experience in working as trained interpreters. I'm on the Maryland court eligible interpreter, so I've gone through that training program. We're on the MVA list, so we can help directly with that, again, free of charge, translating any documents they need for the MVA. So there's no obstacles in them getting a state ID or a driver's license, which is very essential in order to integrate into the community. We're able to provide any of those interpreting services in person, virtual, over the telephone. So we help other small businesses. We maybe disputes between a contractor and someone that hired them. Just simple things, and people just need, just to know what the bank teller is telling them. So we're always available, and any one of us can do that. We can translate all those legal documents as well. And 3 of us here are notary public, so we're able to make sure we can get that ID from them and get any of those documents stamped, again, free of charge. We also have a new service we're providing right now. It's directly going in and helping clients that are eligible for SNAP benefits to get those either renewed or first time apply for them. Obviously, the community we work with, it's been a constant and sustained effort to discourage immigrants from seeking help, which has been very effective for a long time. Obviously, none of that is true at all. It's all false and has been false forever. If a family does need benefits, such as food benefits or medical assistant benefits, that will not affect any type of current or future immigration case. So we're trying to dispel that disinformation campaign that's still going on to make sure families that do need that resource and that benefit do apply and get that food assistance into their household. Go to the next slide. So we also do a number of indirect services, obviously, where the gap is much smaller, and we have identified organizations that just need maybe a little bit of assistance to get a client connected to them. We're happy to connect them, and it's what we call like a warm handoff. So there are lots of English classes provided free of charge. It's just a matter of connecting them to that resource. Any other type of legal services, if they need help with a divorce, custody, a public attorney or public defender, help with taxes, we're able to identify those services and get them connected. Housing, applying for home ownership, getting a driver's license or other documents, birth certificates, we're able to connect them exactly where they need to go to get that. Employment. And then we work very closely with our community programs, YMCA, art museums, summer programs, to make sure that they know how to get their children involved with all the amazing activities we have in the community. So a lot of that indirect services is just sometimes a language barrier, a slight language barrier or a cultural barrier that can be closed very quickly. And we don't need to step up and provide those services ourselves. We just need to connect them to those other agencies. One of the things we do as an organization that we continue to do every day is our youth development programs. We run an after-school program at Easton Elementary. We started this back in 2012 when 20% of the population of Easton Elementary was self-identified as Hispanic or Latino. Now that number is 40%. So a lot of the children still are learning English as their second language, or their parents are Spanish speakers. So we're provide this program primarily for those families to give them some opportunities. We integrate a Cub Scout program into it, STEM, healthy habits, art, and they get that extra meal every day. Right now we have about 74 students in the program. Today is actually our last day for the year. But that's also a way for us as the staff to stay connected to families in a different way. One where we're doing fishing together or having a meal together, and we're not just going over hospital bills or immigration cases. It keeps us grounded as a staff and to make sure that we're working with families kind of in a more holistic way. So that's our strategy why we do the youth development, is to keep us very close to families, and especially those families that don't need our services regularly, to make sure we're still connecting with them and providing services on a different level. So this is kind of an example of one of the ways we're integrating. We do work very closely with other organizations that work with Scouts. We just got 10 girls signed into the troop here. And that's just a way to get them more exposure in our community, connected to different groups. And we're just proud of one of the ways we do connect different outreach programs together. Next slide. So we do outreach. We're always at festivals. We do have a very healthy scholarship program now for first-time college, first generation college. We provide cultural competence training to organizations. We work with Chesapeake College to get our bilingual community trained as interpreters. And we're always available to be at events and programs to either share activities with them or share our information. So how are we structured? We're still a very, very independent type of organization. If you see our funding structure, half of it comes from board and major gifts. About 25–30% now come from contracts. We get direct contracts from different counties to provide the services. Some government grants are primarily for our after-school program, client contributions, and then just general fundraisers and friend donations. So we're still very few strings attached to the money that comes to us. So we're still very flexible on what services we can provide to really match what we're hearing from our clients each and every day. All right, so that's kind of a summary of who we are and what we are and the services we provide here on the Eastern Shore. I'll take any questions you have either about our services or the community we serve, or I guess this is a dental group, how we're what we're seeing in terms of dental insurance and dental care with our population.
Well, I want to thank you. That was very informative. But so I do have a question. Do you know what percentage of the people you work with that do not have access to dental care?
I would say children, it's probably, I would say a little less than 10%. Our adults, it's probably 95% that don't have any type of insurance or dental insurance. So the children obviously is a different case here in Maryland. There's a lot more openness right now and a lot easier, regardless of documentation or status, to get them that care. We do have every once in a while these kind of emergency cases where they're not, especially with newcomers coming into the country, especially from impoverished countries such as Haiti or Guatemala with some severe cases. But since we're in a rural community, Eastern Shore, not a huge population, we've been able to kind of cobble together some emergency strategies to get those cases taken care of. But yeah, most of our children are insured. Most of our parents are absolutely not insured.
Thank you. So I see we have a few hands raised. Dr. Corman?
Thank you. Thanks for your talk today. I appreciate it. I was going to just ask, just because a lot of what we're talking about is barriers to care. And I was just going to see those children that you guys see out there. What are the major barriers for them to be seen, or are there barriers, or are there clinics that are readily available for those kids to be seen and have dental treatment done?
So again, being in a rural community depends. Obviously, those that are here in Easton, which is still rural, it's obviously connected with resources. So I know in the school here, there's a dental hygienist that visits. I know that's getting more and more through Chop Tank and a number of other schools, just to kind of break down that barrier of having to take a day off work, and, having to schedule that appointment to get the children for the dental care. So that's improving. Obviously, there's parts still in the rural community where that access isn't in the schools. It's still not there. But that barrier, I think it's at least being attended to. It's try and get it into the schools so the children do have that option. The other ones are just really do take time. The transportation one, it's just an endless one for being here in a rural community. Family schedules, being low income, and the type of work being done, it's almost impossible or very hard to fit, a 9-to-5 schedule with some dental clinics, to take off work, to program that, to schedule that. So that kind of, we see in a lot of cases delays care until, the stars align and a parent's able to take off work, find transportation, and find that appointment that all fits together. So yeah, I think that's a lot of just outside of being an immigrant or with language barriers. Sometimes I think that's always a hurdle for rural communities. It's just kind of making those factors work. And I don't think it's because of any lack of interest or trying from a lot of groups addressing that issue. It's just sometimes a tough reality of being in a rural community.
Dr. Carlson, you have your hand raised.
Thank you very much, Mr. Peters, for your presentation today. I really appreciate your willingness to present to us. Yes, we do have Chop Tank here on the Eastern Shore, which sees many of the children, and we have also some private dentists. But do you have any dentists who are willing to see these uninsured adults in the area? Are there any dentists that your center is able to work with and maybe will help out on an emergency basis, anything like that?
Yeah. Like I said, I think because it hasn't been every week, we're calling them. These are really kind of limited to, once every 6 months or once a year even. Yeah, I mean, I think on Kent Island and where there's more practices and around, we've been able to identify with a team here, negotiate and work out a deal. Obviously, these are cases that pull at the heartstrings, so they're not a hard sell. We understand we need to do that sparingly. Obviously, if we see an increase, we don't really have a strategic plan on how to deal with higher volume. And if, there's no formal contract we have with physicians to take on a number of pro bono type cases. So that might be something, if we do start seeing an uptick in that and identifying more cases that are falling through the cracks, we can do that. I think luckily, though, it feels like a lot of those cracks are being addressed by Maryland state legislation, and there's been, more access is being pushed to get to at least children for a lot of care. So hopefully that continues that trend, and we can continue that talk with lawmakers to lower any of those barriers that have to do with documentation in terms of getting that health benefit or that dental insurance.
Thank you very much.
Dr. Romaine?
I appreciate your presentation. I have kind of two questions. The first is, with the pandemic, we've had less large scale mom projects that I know we've had before on the Eastern Shore. So do your clients, the people that you work with, talk about that or see any difference in access since those have been more difficult to organize? And then secondly, can you help me to understand, you gave some examples of your staff members going through the process of getting papers and green cards, but as a child, what makes a child able to get Medicaid versus not if their parents are undocumented? I'm just unclear of that. And as a point of information, I'd like to know what your experience is with that. Thank you.
So getting to the mom, I know what you're talking about. I don't know what the acronym actually stands for. I know it's kind of an open venue event where a lot of dentists come and provide a lot of those quick services. Is that correct?
It stands for Mission of Mercy. Mission of Mercy.
That's what it is. Yeah.
Okay.
So what I can talk about is I lived again 13 years in rural Guatemala. No dental access at all. No such thing as insurance. No such thing as anything like that. No free dental, from the government or anything. So there was just no access there. So one of the things that in my time there that was important were these mission groups, usually headed by some dentists. I think where I lived in the jungle, it was a group that came from Oregon. I don't know if I'm saying that right. Oregon, every year. And we'd set them up in the jungle and they'd come down with just everything, just like a 3-day massive event. And that was kind of the culture when people needed those teeth pulled or something done quickly. They would look for those mass events. So culturally, at least with the population I work with, that's something very understandable. And that's kind of the norm. So when I see these big events by MOM being put on, I've seen they've been very well attended to because it's not a hard sell culturally. It's more of the norm of putting them together. So I would be very interested to get those back up and going again, because even though we figured out most everything for children, the parents are still just putting off any dental anything until it becomes a hospital type of visit. And we know that those things are important to do still. So I would love to, after post-COVID, if we can start putting those together. I don't even think you need us. I think they sell themselves. I think that, again, it's a culturally, connecting type of initiative. As for children and kind of loopholes in the law, so some of our children that are here that are undocumented, there isn't any loopholes we can find. And those are the ones where we just patchwork together. A lot of the children, if they come up through what's called the Office of Refugee Resettlement, then there's kind of a loophole there where if we have that document that they're kind of entered the country as a refugee, even though not really, but we've been able to get a loophole in there to get them coverage. They keep telling us, it's only a year we'll provide, but we found that kind of gets ignored and they're able to keep coverage in a lot of cases till at least they're 18. If we can get the parent or the guardian or whoever to start some sort of immigration process with them, whether that's an asylum case or whether that's a special immigrant juvenile visa case, once that gets up and going, that opens a door. We have to prove that they've started that. Then that opens a door where the children can get access to healthcare and dental care. But there you do need an attorney because that's a court type of case. I can't provide that. And right now, to even get an attorney to start a special juvenile case or an asylum case is $6,000 to $8,000 per person. So we strategize with them. If we can get them up and going and we have that documentation that they're at least in process of something, then that opens doors for the children where we're able to get them some insurance.
Thank you.
So each case is different, is all I can say. It just depends.
Thank you. Dr. Doring?
Thank you, Dr. Hughes. Mr. Peters, thank you so much for your presentation and what you and your staff do. So important. I think I heard you say that a couple of your staff has some training in social work, which made me think of community dental health coordinators, or CDHCs. It's a program that we're developing with the ADA, American Dental Association. And what I hear your staff is doing, the CDHCs do, in that they know the customs, the language, and they know the barriers, and they help these individuals navigate the system. How do I sign up for Maryland Healthy Smiles? How do I find a dentist? And maybe even the CDHCs have some dental knowledge to provide at least some basic preventive information. I'm glad that some of the kids are getting the care that they need, but I really feel for the adults, and they're showing up in the hospital emergency room. So I hope you continue your great work, and I hope as a task force, we look at these social work type activities such as CDHCs and move that forward. So thank you so much. It was more a comment than a question.
Sure, thanks. I mean, that's the first time I heard of that. We did participate in the CHW program years back. So 3 of us are that CHW certified. That hasn't really come to fruition in terms of taking off. But if that's something similar, I know we have one of our staff here is actually trained to be a dental hygienist. So she'll probably be leaving us in a couple of years when she's done with that. That's her dream, that's fine. But that might be a good, I think we have the capacity, if we can get more information about how to be a part of that network. I think we have the capacity and the staff that really could take that. So thanks for bringing that to my attention.
Dr. Corman.
Thanks for letting me ask another question. In sort of what we're talking about, and just kind of getting back, because trying to solve what the barriers to care are. It sounds like even if there is an adult program that allows these immigrants to get seen, really the hardest thing is for them to actually take a day off work. I mean, can you talk a little bit about that? Like, adults, I mean, is there a possibility that they would even be able to see a dentist on a 9-to-5 schedule? Or is that what the major barrier is going to be for that population if they had insurance?
Yeah, I mean, so it could have a domino effect once we solve one issue. Obviously, if we solve the documentation issue, that will probably resolve a lot of the work issues and the reasons why they can't take off work and all that stress. But that's a hypothetical at this point. But obviously the biggest barrier is the documentation, which leads to the insurance, which hopefully leads to a better quality of life, better job, better all that. But the reality for work is, if you're working here undocumented, even though in theory the labor laws apply to everyone regardless of documentation, there's nothing to do with status. That's not how people perceive that reality. So they're stressed if they do take off work, they could be replaced immediately or lose that job. The other thing is, because of the income levels, missing a day of work could affect them from paying rents, or affect them from, most of that money goes back home to keep their family safe. And if they're not able to keep that money flowing back to their family back home, that could have real life impacts on them. So the work is primary. It would have to be very dire to get them to take a day off of work. What we do at the office is, like, even last night, I had a guy who couldn't get his medication for his kid because I guess they had a mix up with the birth date. And this was 3 weeks ago, that he hasn't been able to get antibiotics for his kid. And he's like, I just can't get off work till 6:30. So he hunted me down at 7 o'clock at my house. And I just came to the office with him, and we fixed it and figured it out. But we got to make ourselves available, sometimes 6:30, 7 at night. Sometimes I got to make myself available on Saturdays, Sundays. It's tough, and I don't expect that of my staff. But that's just a reality, because a lot of these cases, it just gets put off until it clicks. So we're just trying to find ways to strategize to become more available, even though, again, that's kind of how possible is that? I can't say my staff needs to stay till 8:30 at night because certain families can't get off work till 6 or 7. And that's especially harder now in the summer months, where those work days are going to 7, 8 at night, those landscaping jobs and jobs like that. So yeah, it's always something that we understand here, and we try and do our best to accommodate when we hear that, because it's not normal, I guess, outside of our office, but here in our office, it's a very normal situation where people are hesitant to take off work. So we just try and strategize the most we can, see how we can help, what other resources we can pull in, how we can make it a reality, and that person doesn't have to take off of work. So if that's maybe identifying another family member that can be registered with the doctor or dentist to take the child in, and we can coordinate that. I mean, again, we got to think outside the box on how to connect those things and make it reality, because us telling them, well, you got to take off work, otherwise this isn't going to happen, playing that tough love type of thing, you got to do this, it isn't really going to happen or work with our community.
Well, and I just want to follow up on that, because what you were saying earlier too is like the mission of mercy, that style of program seems to be what resonates the most with this population. Am I correct?
From my perspective, yes.
Yeah.
And again, because
Thank you.
that's what I saw, that's how dental work was provided in most of rural Central America, was that. It wasn't setting up an appointment with a clinic and driving to an urban center. It was, opening up a large event closer to you and just, kind of walk in and get that service. So again, culturally, it's just a lot more appealing and acceptable.
Well, Mr. Peters, you've been a wealth of information, but I have one last question. What you do is so important to that community. Do you know of any other organizations around the state that provide those same services?
I mean, I know of a place in Annapolis called Center of Help, Centro de Ayuda. I don't know the capacity they have, how much training they've had to be health navigators or immigration assistants. The other big one, I know Casa de Maryland. I know they do have a capacity to help with immigration issues. I don't know how much capacity they do with the social aspect in terms of health insurance and health bills and all that. But those are just the other two that come to mind as kind of sister, partner, or similar organizations to ours in the state.
Okay, great. Well, thank you so much for being here. I really appreciate it. Okay, so our next speaker is Dr. Paul Casamassimo. He is from the Children's Hospital and Professor Emeritus at Ohio State University College of Dentistry. So welcome, Dr. Casamassimo, and I will turn it over to you.
Great, thank you. It's nice to be here and be invited to speak. And first, let me commend you on your work. The reform in Medicaid is so important for the people covered. So what you're doing is very important. So the topic was why some dentists don't see Medicaid kids and how do we fix that? So I'll give you some suggestions. I'm not going to give you a lot of facts. You'll get those in your deliberations about Maryland and nationally. I know you've already heard from the ADA Health Policy Institute. So I'm just going to cover several topics. And if we get to school health at the end, I'll try to go over that. So these are my grandkids, and always take an opportunity to show them. So next slide. I have to give a disclaimer. I work part-time for the Ohio Department of Medicaid. I'm the only dentist for 3 million people, and their dental needs, who isn't paid by a managed care organization. I'm paid by the state. So, and also the chief policy officer at the American Academy of Pediatric Dentistry, which is the specialty organization that represents the 10,000 pediatric dentists in the United States. Next slide. So what I wanted to do, there are 3 touchstones that I use in my work with Medicaid, and I would suggest if you all haven't gotten to this mission level is to consider these. And the first touchstone that I use is that we always start out at same care. In other words, everything we would love to enact for Medicaid kids should be the same quality, availability, accessibility as we give to commercially covered children. And very often that's not possible. I'll get into some of that as we go. But same care is obviously better than no care, but same care really should be our objective, and not have to settle for some care in the population we're talking about. Next slide. So this is, I've done a lot of work with different organizations and states on managed care, and I think this is the reality of managed care. And so I'll try to explain this illustration here. So if you look at the column of the stakeholders, we have the state, we have the state's agency, we have managed care companies, we have dental administrators who the managed care companies will hire, and we have the dentist providers, and then we have the members that are covered or who are covered. So as time goes on, the benefits, even though we'd like to think opposite, the benefit really declines as we go down, and the risk borne by the different groups that I've listed there go up. And so when we think about changes in Medicaid, I think it's important to understand how the economics of a managed care system work, why it's desirable to some and not desirable to others. And then in the far right-hand column, there's not a lot of good evidence in dentistry and some in medicine that is equivocal that managed care actually improves care. And in dentistry, we have very little information. In fact, California's involved in a project in its Medicaid system. And some of the preliminary information is that the results are lukewarm and in fact, some cases haphazard. So I think it's important to keep that in mind. So next slide. So I look at a lot of things in my professional world this way because we're focused on children. But what I would encourage you to do, if you, and I'm sure you will, develop a list of recommendations from a procedure standpoint all the way through a system change, is that you start with the child and that whatever that is intended to be, and work your way out through the family, through the community, and into the system, and try to decide if what you are recommending will work in the context of those different orbits around the child, and really be realistic about whether or not those can be accomplished. So those are the 3 things I wanted to cover there, and just say those are the things I use when we talk about, we've gone through things like tobacco cessation changes and periodicity changes in our system in Ohio, and we've considered it, or I've considered it, using those touchstones. So next slide. So I think you know this, the Medicaid is, children are growing faster than commercially covered children. This is an ADA slide. You may have seen it when HPI talked with you. So we know that's happening. The challenge is great. Next slide. This slide is a little busy to read, but Maryland is right above the star. And what this shows shows from left to right, the worst to the best states in terms of how close commercially covered children are to Medicaid kids in their utilization of dental services. And as you can see, you're not too bad, compared to states on the far left, where there's a huge gap between the Medicaid child population and the commercially covered population. So you've got a little movement, but I think optimistically, you have less distance to travel than many other states. So that's a good thing. Next slide. So what do we know about dentists and kids? And I think for those of you who are not dentists, these are true. I've been in dental education and hospital care, dental care for 40 years, and I'd stand behind these assessments. First one is general dentists are not well prepared to treat children. The number of hours that they have are minimal in dental education. The second thing is general dentists would prefer not to treat children. And you know, when I fly in an airplane and hear a child cry, I said, you know, that's money in the bank, because that's how pediatric dentists make their living. General dentists really don't want to see young kids, kids with extensive treatment needs, and children who have special needs. Caries risk is a big topic right now. It's not very well managed in the dental community. The dental community is basically caries reactive as opposed to caries preventive. One of the things we know scientifically is that early childhood caries mean basically tooth decay in kids under 5 years of age, predicts what will happen to them in the future all the way through their childhood and adolescence. So if we can prevent it, we do a good job. If we don't prevent it, we can look forward to having that burden on those children and adolescents, even into adulthood. Another factoid is that if you start a kid, first dental visit 1 year of age, get them seeing a dentist, you will reduce the likelihood of tooth decay, the amount of tooth decay, and the amount of treatment, and obviously costs to a system like Medicaid. We already know, I'm sure you've been told, poor and minority kids in Medicaid are disproportionately affected by dental caries. And then the last thing, which I think you may also know, is that many of the Medicaid policies and procedures that are in place now are really not the standard of care. And so if you get down to the nitty-gritty level of change in the system, I think it's important to go through those and realize that a lot of things that dentists are expected to do really are not contemporary standard of care. Next slide. So it's a little more detail. The dental curriculum for kids in dental school is about 200 hours out of thousands of hours. Children in dental practices, you probably see family dentistry in many signs. It's a loss leader to treat adults with higher revenue generating procedures. I already said the general dental community reacts to caries as opposed to being really good at preventing it. And our goal should be prevention. The other thing which I think is important to note as you try to increase care of children is that the Medicaid population, and some of this relates to a lot of what Matt said earlier, they have unique problems that really general dental dentists are not able to deal with. Pediatric dentists, nationally, a third of our practices are Medicaid kids. I don't know if that's come out, but we're the highest provider of Medicaid kids. We're used to doing case management and things like that. We do better. General dentists really don't do that. And then the last thing again, and I'm happy to talk in more detail about this later on, is there are some Medicaid policies. One is pre-authorization. Another is frequency of restoration. Another is this concept of doing the cheapest possible treatment on a kid at the front end instead of doing a procedure that is going to last the length of the tooth, of the baby tooth, and may cost a little more initially, but actually cost less in the long run. So there are a lot of procedures that we do that, and a lot of Medicaid rules and regulations that just are not contemporary and in the best interest of patients. Next slide. So let's cut to the chase. What can we do to get dentists to see more kids? One which nobody likes to hear, but and I heard you just had a fee increase working its way through the pipeline, is increase dental fees and get them to at least 65% of commercial fee levels. There's some disagreement whether fee increases by themselves increase participation, but when you team those with changes in administration and you make both of those meaningful in terms of amount and quality, there's clear evidence that more dentists will participate in the system, and you'll also retain them, and facilities and programs like Matt talked about that are sustained barely in many cases to help the uninsured, it allows them to keep going. So there's a lot of other reasons to increase fees. Selective incentivization. There's a project around the country called the MORE project, which teams up pediatricians with dentists to see kids early. And as I said earlier in my presentation, there's very, very good evidence to show that if you start a kid at 1 year of age, you're going to save money and save a lot of human suffering by doing that. The next, number 4, is focus on very young kids, as I said, and then kids with special needs. We just submitted a project looking at tens of thousands of Ohio kids with behavioral health issues. And what we found is that those kids tend to get fewer preventive procedures. They need more restorative procedures, and most of them need to be treated in an operating room as opposed to a dentist's office. And in the 7-year period that we looked at, there was an excess cost of over $10 million because there was not early intervention. So there's a lot of savings to be gotten if you can get kids earlier and focus on kids with special needs. Number 5 is somewhat controversial. And as a dentist, and we have a few dentists, I don't know how many of you are dentists. If you looked at if you remember my managed care thing, the risk is disproportionately on dentists. And I think one of the things that any Medicaid task force needs to do is to get the managed care companies at the table and have them bear their share of risk and be creative on how we can all work as a team as opposed to competitors, which is the way the system works now. How you do that is the challenge. Kids need to be able to get to the operating room. You all are more familiar than anyone else in the country about Diamine driver. We're waiting for the next Diamine driver because kids can't get into the operating room to get their teeth taken care of. And it's just a matter of time before we see another child who dies from some complication of early tooth decay. So if you can make those kinds of services available, please do so. There are some creative approaches, things like federal qualified health centers contracting with dentists to do services that they can't provide because they're overwhelmed. That's something that should be supported by Medicaid. And then have some periodic, you're a task force, I'm assuming you'll disappear once you've made your recommendations, but one of the failures of the Medicaid system is to not at the state level and the federal level to have an ongoing professional advisory group to make recommendations based on standard of care and also to look at data. Medicaid does not do a very good job at using its data to improve the system. So, and then the last thing, and I don't know if this is on your plate or not in Maryland, but increase or create a meaningful adult dental benefit. And I think my next slide shows something to that effect. Ohio is, I'm pleased to say that we're one of a handful of states that has a meaningful adult benefit, in some cases better than some commercial plans. And when you get the parents of children into a dentist and dentist care, the children will come as well. So A meaningful adult benefit is something, and I think the health policy folks, when they talked to you, said that it's 1 to 2% increase in the Medicaid budget. It's not very much money, surprisingly, to have a meaningful adult benefit. Next slide. So those are my suggestions. I went through those very quickly, and I got a few more things to talk about. One was I was asked to talk about school-based care. And if you go back to my diagram of no care, some care, same care, this is an example of where maybe you have to you say, well, in the circumstances we have, if we have kids in school and we can put some kind of dental facility or some relationship in that school to get those kids taken care of so that they get some care versus no care, that should be something looked at. So we do that here in Columbus, where I live. We have a program that goes to a suburban school system. But the difference, or the fiats that are involved with this, is that we provide a whole range of services. We have after-hours emergency care. We have referral sources that are meaningful. We have parental participation. So it looks like a private dental practice. And really, if you're going to do this and try to emulate same care, that's what it has to look like. It should be integrated with any school-based medical care. And the challenges are always consent, follow-up, after-hours care, the things I have listed in yellow there, parental consultation. But the benefits are that some kids, this is their only access to care, and they'll have minimal lost school time as opposed to taking a half a day off. There's the relationship with the sports programs, and the records are available. So there's a lot of pros and cons. Ideally, we like kids to have a relationship with a dentist in the community, but if that's not possible, school-based care is a proxy approach. Next slide. I was also asked to comment, and I'll do it briefly, about school readiness screening. Some states have instituted a requirement that a child be seen by a dentist before beginning school, and our specialty organization supports that to the degree that it kind of creates a bar to get over. The bar should not be a wall. In other words, it shouldn't prevent a kid from going to school or penalize them, but it should be a way to screen our population of kids so that they're all able to have at least some interface with the dental care system. So the fear or the thing you worry about is when you have companies that come in and they do all the easy stuff. They do the exams, the cleaning, the fluoride treatment, and the sealants, and the kid still has tooth decay, and then there's no source of care. So if you look at that in more detail, there are a lot of models out there that work that can, that you can look to. Illinois has one, California, I believe, has one, that kind of requirement. Next slide. The last thing that I was asked to talk about briefly was the role of silver diamine fluoride. It's a liquid that's painted on tooth decay to stop it, or at least slow it down. And it's used all over the world in places where kids don't have access to dental care. It's got its pros and cons. It stains the teeth. You have to really monitor these kids in some cases more frequently than if you did routine dental care. It can't be used as a substitute for routine dental care, and that's kind of the concern that we have, is that you paint the stuff on and you never see the kid again, and that's just bad care. And there are consequences to that by not seeing the kid periodically and not knowing what's happening with new decay, if that is going to occur. So the bottom line is to say that SDF has a role. We use it at our hospital. We use it sparingly and in concert with traditional restorative care, and that's the way it should be used. So the next slide, I won't spend a lot of time on it. This is just some examples of what we call non-surgical management, and silver diamine fluoride fits into that paradigm, which fits into the traditional filling and crowning and other treatment of teeth. So it does have a role. We pay for it in Ohio Medicaid. We have very specific regulations regarding its use and guidelines. But if you're going to consider that, I would say do so. So I covered a lot of stuff, and so I'll take any questions you might have.
Oh, thank you so much, Dr. Casamassimo. So I have good news that your slide representing the states that don't have adult coverage will need to be changed. Maryland is no longer on that list.
Good.
Yes.
Great.
So the plan is effective January 1, adults will have coverage.
Good.
And not limited.
Unlimited.
Well,
Oh,
I mean, there are
wonderful.
always limits, but
Yeah.
more comprehensive than, it's not just emergency. So we're really happy about that.
Good for you.
Okay, I have one comment before we get to the hands raised. You know, you talk about general dentists aren't prepared or don't want to necessarily see children, but you have to look at the number of pediatric dentists that are trained compared to general dentists. So how do we address that to make general dentists more comfortable? Because the likelihood, every child can't see a pediatric dentist. The numbers just aren't there.
Sure. You know, and that's an excellent point. And in the list of suggestions that I gave you is to try to incentivize dentists. You know, I'll use special needs patients as an example. You know, in the extreme, a child with severe disabilities and problems probably shouldn't be treated by a general dentist. But there are a whole host of kids who are in the middle who their only disability is their label. Mm-hmm. And so they can be treated by general dentists. So what we need to do is make our system so that a Medicaid kid looks as desirable to the general dentist as any other kid. And so that's my list of suggestions were aimed at that, you know, to try to create a parity or an equity amongst all children. So you're absolutely right, though. I mean, the ratio is like 20 to 1 or 25 to 1 general dentist to pediatric dentist. So we can't do it all. So.
All right, thank you. All right, first hand, Dr. Romaine.
Thank you. I guess my question kind of segues into what Dr. Hughes just said. Thank you, Dr. Casamassimo, for coming to speak to us. Always so good to hear your presentations. I practice in a rural area of Western Maryland. So you know how Maryland is like a long bow tie. So if you take halfway in the state and you drive 2 hours west to the border of West Virginia, there is no pediatric dentist. Mm-hmm. So from a policy point of view, like with your position even involved in the American Academy of Pediatric Dentists, do you know of any state programs anywhere in the country that tends to like bring pediatric dentists out to rural areas more readily or is successful at doing that? Because that is a huge barrier to care here, where, you know, happy to take care of kids. I love taking care of kids, but some I just can't take care of. And for their parents to drive to Morgantown or to Frederick is impossible. Mm-hmm. You know, those are both 1.5 2 hour drives for parents without resources. So do you see any places we can emulate or model?
Well, you know, it's a good question. There's a hot dog place in Cumberland, Maryland, when I drive through there that I stop. So I can't think of the name of it, but I know where it is. You know, one of the things we're trying to do, we have
it's Coney Island.
Oh, okay. Thank you. We have this Title VII program that's going on for over 20 years to increase the number of pediatric dentists, and our numbers have actually doubled in that period of time. It's a federal program, and we're realizing that it's come to a kind of a point where we just don't want to be putting more pediatric dentists in Baltimore or Columbus, Ohio. We need to put them where they're really needed. And so one of the things to do that is to try to get the federal government to shift that program and incentivize people to get their education paid for and have them practice in rural areas. So that's, that's one thing, and that's been tried, and it's, it's successful in some places, not successful in others. Another thing that seems to work, and it works in states like Nebraska and Iowa, is where you have a hub and spoked kind of practice arrangement. So you have a core practice in a more populated area, but then the dentists, singular or plural, will go out to a rural community and be there for a couple days a week. And the benefit of that is they get specialists, the patient pool gets specialist services, and they also get this conduit or pathway to things like orthodontics, operating room care, sedation, and things like that. So that's another model. We're trying to push that model more as a solution to a lot of things, not just the lack of access. But so that's another thing. And National Health Service, has programs that will pay you to be in a rural area. So there are some programs, but the reality is that you're not going to find a lot of people who want to do that, who want to live that lifestyle. They'd rather be in the big city. And so that's our challenge. So I don't know if I gave you some answer, but not, the absolute answer. So I don't have it.
Thank you. Dr. Doran?
Thank you, Dr. Hughes, and thank you for your presentation. Very, very worthwhile. I'm a general dentist, and my staff calls me the bunny tail king because I love seeing kids. It's something I enjoyed in dental school and continue to do that. And I do agree that there's some kids that are best treated. And as a general dentist, we need to draw the line, what's going to give a most positive effect for that child so that they'll feel like coming back in the future. So I just wanted to say, I do recall maybe 10, 15 years ago, the Maryland State Dental Association had a pediatric dental residency for general practice dentists to learn some special techniques to use on those kids to kind of be able to treat them. And certainly the SDF is going to be part of that training. So it might be worthwhile. Hopefully we get through the COVID-19 and all get together and do some kind of little mini residencies. But I do think some continuing education, because as Dr. Hughes says, the bulk of the care is going to need to be provided by general dentists. And that's what we want to recruit for our Maryland Healthy Smiles Medicaid program. The other thing to follow up on Dr. Romaine that we've discussed in the elder group is when you're in the remote areas, and we know what the tuition is for dental students, the incentives aren't enough anymore to relocate your family to a more remote area. So we need to do that. And also the insurance reimbursements based on zip codes are a problem, because if you're in a more rural area, your reimbursement is going to be less than, say, in Baltimore County or Howard County or Annapolis, where the reimbursements are greater. So again, that's less of an incentive. That's less income for a young dentist to relocate into rural areas. But I do thank you for your presentation. It really gives a lot of food for thought. Thank you.
Good. Thank you.
Christy, you're next.
Thank you, and thank you for the presentation. So I am not a dentist. I work with the Maryland Developmental Disabilities Council and sit on a lot of healthcare advisory committees. So my question, you said very briefly something about care coordination and the dental medical home. And in healthcare in general, especially when we talk about pediatrics, a lot of times we talk about the medical home and coordination of care. So my question is really, do dentists tend to coordinate care with pediatricians or with general practitioners? And is that something that is beneficial, that we should look for more? Or are they completely separate and we should look at these as two different sets of healthcare practice?
Well, it's a great question, and I don't know if I give you a simple answer. There's a strong belief, and a report just came out from the National Institutes of Health, by that was originally supposed to be a Surgeon General's report, but one of the key elements of it is medical dental integration, and not just for kids, but for all ages. And so there are a lot of projects that are ongoing and that are about to begin. I mentioned the MORE project, which I think is in Pennsylvania, and we're going to start one in Ohio here soon. There are programs in Denver, Colorado, and California that do link dentists with pediatricians. But all of the things that I've talked about is we got to get dentists willing to see these kids. And in communities where the dentist is overwhelmed with the amount of tooth decay in their community, they're a lot more willing to try to figure out how to make this work, because they're the only ones who can take care of those kids. And so, like in rural Ohio, southeastern Ohio, we have general dentists who are going to jump on this and have already established those relationships. So part of your question was, do we need more of it? Yes, we do. We really don't know how to do it well. We don't know how to get the medical community to do what they need to do, and to get the dental community to do what it needs to do. So I think these projects now will become far more common once this report is digested that has come out of NIH about the future healthcare. Now, the downside is we just learned that only 90% of our dentists in the United States take a health history. So there are 10% of the dentists never ask about health other than teeth. And so we got a ways to go. I mean, and the payment mechanisms, the structure of the systems. I know some of you are in social services. All of those case management things that need to be done. This is an evolving system. So I'm optimistic it's going to get better. And as I said, the pediatric dentists are used to doing this, just like pediatricians. But when we go to refer special needs kids or somebody to the adult community in both medicine and dentistry, we run into a brick wall because they don't know how to do it or don't want to do it. So there are still a lot of challenges.
If I may, Dr. Hughes, ask one follow-up question.
Certainly.
So I believe that it is true that Medicaid also does not reimburse for coordination of care or care management. Is that correct?
That's in dentistry.
So the coordination between the two health offices would not be reimbursable, which also decentivizes that coordination of care.
In Ohio, it may be different in states. In fact, care management codes in dentistry have only recently been listed, and a lot of them are listed but not paid for. And that's true in Ohio Medicaid as well. So we don't pay for those services, unless it comes through a medical facility of some way or is prior authorized, and that is very rare.
Thank you.
Dr. Corman.
Thanks again for the presentation, Paul. As a fellow pediatric dentist, and just to dovetail on that last discussion there, I will say in practice, there's not a big core connection between the medical community and the dental community at all. I mean, even with just trying to discuss treatment alternatives, treatment options, with kids that have medical issues going on, I think the education on the medical side about dental care and what's going on dentally isn't there, and it's not expected to be there either. I mean, they have the whole rest of the body to deal with, and our job is supposed to be the teeth and the oral cavity, but it's hard to coordinate that, and I think that's a big barrier sometimes a little bit. And it goes to kind of what another thing that I want to touch on in the presentation, that I feel like when we talk about general dentists treating kids, I mean, yes, I agree. I think, like you've heard before, I mean, all the general dentists that we're speaking here see lots of kids in their practice. I think the hard thing is most general dentists don't see children under the age of 3 or 4. And, if we want to really tackle this idea of prevention of decay, I mean, that starts at age 1. And really, I feel like when you graduate from dental school, you get zero training on seeing a kid that's 1 year of age, and things like that. And so going back to the issue of the coordination with the medical providers, I think the medical providers also don't make that connection that kids need to be seen early at age 1 also. And there seems to be a disconnect on that importance of that age 1 visit. And so it's kind of this vicious cycle that just keeps happening. It's like, we know prevention is the one thing that's going to help the most to sort of, as time goes forward, stop, decrease the number of OR cases, decrease the number of decay that's out there and things like that. But I think the bulk of kids aren't being seen till they're, say, age 3 or age 4. And then by that point, I'm not saying all kids have decay, but there's a lot of kids, and especially as you go down in socioeconomic status, the amount of decay that's present in those kids, I mean, we say it all the time, is the number 1 most preventable disease, in childhood. And so I think like that when I think about barriers to care, I mean, somehow this education piece, and it's education not only to the community, but to the medical community and to the dental, it's kind of this triad of somehow we got to like nail this point home so these kids are getting in, appropriately at age 1. And at least, my thing is if, as a pediatric dentist, if I was just seeing 1-year-olds and doing prevention all day long and also treating kids that had, special dental needs and that couldn't be treated, I mean, that's what I envision a pediatric dentist doing, is taking these 2 parts of the spectrum, and general dentists filling in that, that middle ground of the kids that, can just be seen on a normal basis. But I think it's hard for the public, and it's hard for medical providers to kind of know what it is we do as pediatric dentists, because I mean, most of the kids that we see, I mean, when people talk about behavior management issues or things like that, I mean, sometimes we have kids that are literally like, combative, like trying to like get out of the room. I mean, it's not just like, oh, they're like crying a little bit or things like, I mean, these are kids that have like extreme anxiety, and which I will say since COVID has probably gotten worse as far as mental health issues with kids that we all know. And some of these sort of issues are becoming more difficult to manage. So I don't know, it's for me, when I look at it as a pediatric dentist, there's just like this, somehow this like wheel keeps spinning, and I'm just trying to figure out, and I mean, I know we're all trying to figure out, but like, how do we like stick in the tire to stop it from moving, and like, sort of be able to all be on the same page a little bit. And so that's what, I just, when I'm thinking about how we reduce decay and how we gain access to care and things like that, I mean, I think this is like one of the biggest things that we gotta think about.
One of the things, and I don't mean to minimize or catastrophize either way, but once you've gotten early childhood caries, it's like HPV or HIV. You always have it. You're always susceptible to tooth decay. And the only way to not be susceptible is to not get tooth decay. And I don't know that many dentists, much less the general public, realize that once you're infected, you're infected. And even when we fix the teeth, you're still infected. So, that's why what you just talked about is so critical, is to prevent it from ever happening in the beginning. So,
yeah.
So I get, and there's a chat about the reason we want pediatricians to see kids under 2 is because they see them so frequently, like 8 times in the first couple of years of life. But then after that, they might see them once a year or episodically, whereas dentists, if they have a regular dentist, they go twice a year. So we're likely to see them more often than the physicians do. So, that's the reason for this paradigm of early visits and then, switching over to the dentist who may see them more frequently.
Charlie, I see your hand raised, but I really need to make a comment or question about the medical dental collaboration. In Maryland, we have a fluoride varnish program where pediatricians are allowed to apply fluoride varnish up until age 5. What are your thoughts about that type of program to help with prevention?
I think it's great. I mean, we strongly encourage, we've got a program in Ohio that's been around for a decade or more to get pediatricians to apply fluoride varnish. And, and I think this is probably true in any state with a dental association, the initial thought was, well, you're taking money out of our pocket, but the reality is that we want the best for kids. And so we voted to make this a procedure that goes all the way to 5 years of age in kids being, applied by physicians, because a lot of kids don't get to the dentist. So the fluoride varnish application by physicians is very important, and how that mixes with dental care. It shouldn't be seen as a substitute. They used to talk about fluoride varnish as the vaccination against tooth decay, and obviously that wasn't true. But we really need to refine what you just talked about to make that transition to dental care for as many kids as we can.
Certainly. And do you have high utilization? Because we have pockets of the state where it's highly utilized and others where it's not at all.
Yeah, exactly the same. And in an affluent middle class community, it's less common. In a poor community, in a rural community, it's far more common.
Mm-hmm.
So
okay, thank you, Charlie. I'm sorry. Go ahead.
Quite all right. Just to tag what Dr. Koyman said, and we're both on the advisory provider for Maryland Healthy Smiles. And I'm trying to go off the top of my head. I can't find the document, but someone asked in the chat utilization for kids in the past year for dental visits. And I wanted to say it was around 53%. But I wanted to bring up the point, and that was kids that had gone to the dentist, enrolled in Maryland Healthy Smiles within the past 12 months. The point that prevention for kids really needs to start in pregnancy. And we have, through Maryland Healthy Smiles, a program for pregnant women, and utilization is even lower. So we're not getting the OBGYNs telling the pregnant females, hey, you have dental care available to you, in which we can do some dental exam, clean the mom's mouth, because we know they're going to transfer that bacteria in the same type of diet to their small child. And if the mom has caries or a parent has caries, they're going to pass that on to the kids. So I think we really need to groom this physician dentist model that we're all communicating and we're all working the same direction. And it really starts with the pregnant mom. So that was my comment. Thank you.
Dr. Koyman?
Yeah, just to add to that, yeah, you're right. And I think it's about 17% of pregnant women utilize Maryland Healthy Smiles. So it's a really low number. But, and so going to the fluoride varnish, Dr. Hughes, like you were talking about, and I think, and I'd like to get, Paul, your take on this. I mean, sometimes I feel like, again, we're like shifting the onus from the dentist to the medical provider, because we're still not, pushing that early visit. So the only reason, I mean, we dentally should be pushing, what I'm saying, like the education, I think really needs to really fire in on, like, you need to see the dentist age 1. So we as dental providers that know how to place fluoride varnish in the appropriate way and can evaluate the oral cavity, these things can be happening prevention wise, is the important part. I'm not saying that right now, the situation we have where that's not happening, yes, I think it's good for medical providers to be doing it. But it's hard, when I speak with medical colleagues and stuff too, and I'm just wondering, Dr. Casanasimo, if they have this in Ohio, most of them, really like read an article or read a blurb on the packaging of how to apply the fluoride varnish. I mean, they don't really go through a quote unquote training program on it. And so it ends up, they say they always have so many things that they have to get through on a wellness visit and things like that, they're just kind of like putting the fluoride varnish on there as just another step in the process. And so I agree. I think in the beginning, when these policies first came out, like in Ohio, I think fluoride varnish was viewed as this silver bullet that was going to stop all decay from happening. And if you put it on there every month or, every 6 months, like decay was going to go down. And, we kind of saw that not happen over time, because I think the education and diet component is really important. But, I feel the same thing about SDF right now too. I mean, I feel like SDF in this last year or two has been sort of promoted in the same way, and we all have this idea that it's this silver bullet that we're going to use SDF and we can arrest decay, and it's gonna we can solve all these kids that are in pain or have problems, and but I think as time is going on and more people have been using SDF, SDF is merely a placeholder for traditional treatment. It's just, I'm going to see this kid in 3 months and I just need to kind of slow down this decay till I can do the, restoration. And I think I just see so many similarities with that. So, I think, as we go down and we come out with these materials and we introduce them, as we go forward, it's just being careful, there's an education important that I think is really important with it too.
I agree. In Ohio, if for a physician to apply it, they would have had to take an hour CE on how to apply it. And it was all hands-on CE. It wasn't a bunch of theory. It was, doing it in your office. So.
In Maryland, it's a video course.
Mm-hmm.
So do we have any other questions? Oh, Mary?
Yeah, I just want to comment and echo what Dr. Doring said earlier about the importance of oral care, prenatal and postpartum, and working with our partners and stakeholders throughout the state and the department who distributed an excellent oral health during pregnancy guide in 2019, and I think just updated it, that I believe, Dr. Hughes, if I'm correct, was distributed to providers as well as dental and prenatal providers statewide. And I think that's something that we need to really elevate again in terms of the importance of bringing up oral care during the prenatal and postpartum period, and especially postpartum, which was extended to 12 months now, which really addresses, early action on a care at a very early age for Carrie's interventions. So thank you.
So
I'm sorry.
Oh, I was going to say real quickly, we have some preliminary data in Ohio, and that it speaks to the lack of use of dental services by pregnant teens, pregnant women who are older, the general population, women in general. And so the variation is not all that great. And so what it says to me is we need to do a good job on our Medicaid patients way back, so that good oral health care carries through pregnancy, postpartum, and is not seen as this thing that can be lost for 9 months and not done. And so we haven't looked at that information in more detail, but really, if we can get good oral care for our clients or members in Medicaid right from the outset, we can really get that inculcated into thinking of all people. So.
Dr. Corman, you have a question?
Yeah, just really quick. I just want to ask your opinion on one thing. Just because, and it's a little bit off topic, but it kind of goes into, as I'm thinking about the future and as adult Medicaid comes on board going into 2023, you know, and I think the number is we're going to be adding about, I believe it's 500,000 to 600,000 new members, but it's tough to know exactly how many because, you know, nothing has been shaken out yet. But I mean, we're essentially more than doubling the number of patients that are going to be sort of on Medicaid in the state. And what I worry a little bit about is, you know, workforce as far as providers to handle all these new members that are coming on board. And I'm hoping that we can get more providers, but, you know, one of the genesis of this oral health task force was the dental therapist issue was kind of why this was created. And where do you see dental therapists or mid-level providers going as you're looking down the road, or looking at the past and looking maybe 5 years forward? I mean, what's your feeling on it, what you're seeing?
Dr.
Well,
Corman, if you don't mind, we're going to have that discussion at our next, because it's going to take, unless Dr. Casamasino, you can say it in 2 minutes.
I can say it in 2 minutes. I can say it in 2 minutes.
Okay, say it in 2 minutes.
Okay. Well, I think you need to tread carefully. There are many passionate people in the public health community who believe this is the solution to access to care. And if you look at Minnesota as the poster child, they've had it for over a dozen years. And right now, dental therapists are 1% of the dental workforce after 12 years. And so that's one thing to consider. Number two is that it's touted to go to rural areas, and the vast majority, over 2/3, practice in Minneapolis, St. Paul. So you got to be careful where you put your bucks. And if you're going to really try to improve Medicaid, we talked about the number of dentists that there are. There are dentists, dental hygienists. We have alternatives, physicians. I personally don't discount what dental therapists do, but to think that they are going to solve the problem in the lifetime, I hate to say it, my lifetime or yours, for many of you, is naive. Truly, Minnesota is an example of a well-intentioned idea that has gone nowhere. So Maine has one, I think, practicing dental therapist after 3 or 4 years of it being legal. So you really have to decide where you put your money. So I think I'm under 2 minutes, but England hasn't improved they've got dental therapists, hasn't improved their system for kids. In fact, they're one of the worst. And so I think you really need to think long and hard and put the passion aside and decide whether this is a valid solution or a unicorn that we're chasing. So that's my opinion.
Great, thank you. Any other questions? Well, I'd like to thank our speakers. You've given us a lot of information to think about how we move forward. I also want to thank Drs. Carlson and Corman for their recommendations. They recommended our speakers today, so thank you so much. We really appreciate you being here.
It's my pleasure. Thank you for having me.
Certainly, yes. Okay, so next on the agenda is next steps and action items. So as I mentioned, our next meeting, we will have speakers that will discuss dental therapy. We hope to have someone from Minnesota. We have someone from the ADA that's already confirmed. And also for meetings for July or August, if anyone on the task force has any recommendations for speakers, we welcome the suggestions. In terms of action items, I've talked about the committees Does anyone need a reminder of who's presenting for June, July, and August?
I'll send that out via email to everyone as well for the benefit of the folks who couldn't make this meeting, and just so you've got it written down somewhere.
Great, thank you so much. Before we leave, I'd like to acknowledge Delegate Bagnell's presence and her consistent presence and support. Thank you so much. Is there anything you'd like to say before we go?
As always, I appreciate the work and the commitment to making sure that we have that we have recommendations and policies going forward, because I know it can when we're in the weeds, it can feel like where are we going, and I know that that this task force is on a trajectory and has is committed to really finding real solutions. So thank you for that.
Thank you. Is there anyone else that has anything they'd like to say before we depart? Once again, thank you. Thank you to our new member, Nancy Brown. Thank you to everyone and their dedication to making sure that our Maryland residents have the best care possible. So if there's nothing else, have a good day and afternoon.